Yeah, I just unmuted and I just turned the video on. Okay. I think this works. Hello, everybody. My name is Akhil Chandra. I'm one of the fourth-year medical students. I'm here today to present about rotator cuff arthropathy, diagnosis and treatment, as well as reverse total shoulder. So these are the objectives. Essentially, I'm going to speak about how to, sorry, I'm going to advance this as well. I have two different slide decks open because of technical issues. So the objectives of my talk are to briefly discuss how to diagnose rotator cuff arthropathy and to identify common radiologic findings with it, as well as some of the treatment options for it. And at the end, I'll present some literature on reverse total shoulder. So the patient was a 65-year-old female who presented with 1 month of persistent, sharp, and constant left-sided shoulder pain on abduction and overhead activities. She denied any numbness or tingling. Of note, she presented originally in March of this year with right greater than left shoulder pain and underwent hemiarthroplasty on the right side in April of this year. She represented with the left-sided shoulder pain and then was consented to undergo a reverse total shoulder. I think out of her history, the main pertinent findings are that she has a prior medical history of rheumatoid arthritis, as well as lupus and Hep C. She's right-handed, she's retired, she was a former smoker. However, she denied any alcohol or drug use. The information that I had on her physical exam was a little limited, as I had only seen her in the OR, and some of the computer systems were down this week. However, from the chart and what I was able to glean from the operating room, as well as some information I was able to obtain from the patient herself, in terms of her shoulder exam, she had no atrophy in her shoulders bilaterally. However, she did have mild swelling on both sides. She had equal shoulder height, no deformities that I was able to notice. Her skin was normal overlying her shoulder. She had no bruises. There was tenderness on the left side, not as much tenderness on the right side. The right side was the one that had previously undergone a hemi a couple months prior. She had very good passive and active range of motion on the right side of her shoulder. However, on the left side, she had a pseudoparalytic left shoulder, which essentially means that she had an inability to raise her left arm greater than 90 degrees in setting of a rotator cuff tear, which I'll speak about. Due to her rheumatoid arthritis, she also had splenic deformities on her hands bilaterally. And during EUA, I was able to notice that she had near full passive range of motion of her left shoulder. However, in terms of active range of motion, her left shoulder was pseudo-paralyzed. So two different AP views and an axillary view of the left shoulder were available to me. As can be seen in the radiograph on the right of the screen. Pull my mouse over to the side. There's superior migration of the humeral head that can be seen right here with decreased acromial humeral distance, also known as decreased joint space. There's also acetabularization of the coracoacromial arch, which is a pseudo-articulation of the humerus with the undersurface of the acromion, and this causes acromial erosion as well as increased sclerosis. She also has some arthritic changes, which again, the joint space narrowing, which can be seen here, some osteophyte formation as well, and some subchondral sclerosis, which I had previously mentioned. Colloquially, this is known as a high riding shoulder, and it has a very high incidence of rotator cuff arthropathies. These are two of the patient's pre-op CT scans. Again, you're able to see some erosions and osteophyte formation. And as well, you can also see like some of the high riding shoulder on the side. With the narrow joint space there as well. So rotator cuff arthropathy is a degenerative joint disease of the shoulder that occurs from a rotator cuff tear leading to abnormal glenohumeral wear, as well as a migration of the humeral head superiorly. It's more prevalent in females than males, and symptoms include pain, weakness, and stiffness. You usually can diagnose it with an X-ray. You don't need advanced imaging. And some of the findings are, as I had mentioned previously. It's characterized by a combination of rotator cuff insufficiency, glenohumeral cartilage destruction, superior migration of the humeral head, subchondral osteoporosis, as well as sometimes collapse of the humeral head. Risk factors include a prior tear, rheumatoid arthritis, crystalline-induced arthropathy, as well as hemorrhagic shoulder in the elderly on anticoagulants or hemophiliacs. And typical physical exam, you'll find sometimes atrophy of the rotator cuff musculature, as well as difficulty with range of motion. In our patient specifically, we were able to notice that she had pseudoparalysis of the left shoulder. And as I mentioned before, this is inability to abduct the shoulder past 90 degrees. In terms of treatment options for this condition, first line includes activity modification, NSAIDs, as well as physical therapy. However, when that fails, surgery is a second line option. As I'll go into in the coming slides, an anatomic total shoulder arthroplasty, or the typical total shoulder that we think of when we think of total shoulders, do not work for this specific condition because you need an active rotator cuff for that to have proper functional outcomes. So the two options that we have are hemiarthroplasty and reverse total shoulder arthroplasty. However, while hemi would alleviate the pain, studies as well as functional outcomes in patients with this condition that undergo hemi are variable. Consequently, reverse total shoulder has emerged as a very popular option for patients with this condition. And one of the classification systems for rotator cuff arthropathy includes the Hamada classification. And from my understanding of our patient, I believe that she has a 4B classification on this grading scale. Very briefly, I know a lot of folks know rheumatoid arthritis really well. However, it's a type 3 immune complex mediated reaction, affects about 38 in 100,000 individuals in North America. Anti-CCP antibodies are very specific for this condition. Positive RF titers and elevated ESR CRP are sensitive, not specific. The glenohumeral joint is very commonly affected. Treatment usually includes DMARDs. You usually start with methotrexate, and then if that fails, then you can go to other DMARDs and use them in combination with one another. You can also use TNF inhibitors as well as biologics. However, in the setting of our patient, she also had Hep C, so the concern was about trying to balance immunosuppressing her too much and then having her Hep C go uncontrolled versus providing her with some sort of treatment for her rheumatoid arthritis. So what is a reverse total shoulder? So a reverse total shoulder essentially is a total shoulder. However, you reverse the polarity of the implants. So where the glenoid is normally a socket, you turn it into a ball, and where the humerus is normally a ball, you turn it into a socket. And it was originally created to address rotator cuff arthropathies. And the idea behind it was that by medializing the center of rotation and translating the humerus inferiorly, the reverse total shoulder tensions the deltoid, and it becomes the main muscle that is involved in utilizing the shoulder because it functions as a lever arm. And so that's why you don't need a rotator cuff necessarily when you have when you use this condition, use this procedure for patients with rotator cuff arthropathy. And this is actually a post-operative graph of our patient. So the first prototype of reverse total shoulder was found in 1970 or so in the UK by two physicians there. However, it wasn't officially published in the literature until 1987 by Grumont, who introduced it as a modality to treat rotator cuff tears. It was very popular in the UK and France. However, it didn't make its way over to the United States until 2004. The FDA approved it that year. And then in 2007, there were 10,000 reverse total shoulders performed. And then in the year 2012, that tripled to 30,000. In terms of the incidence of this procedure from 2012 to 2017, there were 7.3 per 100,000 patients that were treated with reverse total shoulder in 2012 versus about 19 out of 19 per 100,000 patients that were treated for this condition in 2017. So in 2017, there were about 63,000 procedures or so. And I thought this was a good image of a reverse total shoulder. Sorry, this is the total shoulder or anatomic total shoulder. This is the hemiarthroplasty, and then this is the reverse. So the indications for this procedure, while this procedure was originally created for rotator cuff arthropathy, the indications have expanded significantly since then. And now it's also used to treat osteoarthritis, prior failed hemis, malunion, non-union, acute 3 or 4 part proximal humerus fractures, as well as tumors of the proximal humerus. And something interesting I found is that when I was researching this topic and I looked up various implants and medical device companies, their approvals through the FDA are actually published online, so you can see exactly what each implant is approved for. Officially, off-label uses probably not going to be listed on there. Contraindications include axillary nerve damage, as well as a non-functioning deltoid muscle. As we discussed, the deltoid becomes a primary muscle that's responsible for shoulder movement after the surgery, so consequently, you need a deltoid muscle that's functional. Glenoid vault deficiency is also a contraindication because this would preclude proper fixation of the base plate. And infection in neuropathic joints are also contraindications. So in the normal shoulder, the rotator cuff actively stabilizes the glenohumeral joint by compressing the humeral head against the glenoid. However, when you have rotator cuff dysfunction, the ability of this musculature to generate what's called concavity compression becomes compromised. So the humeral head translates superiorly into the glenoid. And this is what you see on radiographs, and also it's called like a high riding shoulder again. And as I previously mentioned, in terms of using an anatomic total shoulder, it's really dependent upon a functioning rotator cuff. So that wasn't a possibility for our patient. And in terms of utilizing a hemiarthroplasty for our patient, hemis offer unpredictable hemis have unpredictable options. Sometimes they offer pain relief, sometimes they don't. But research in one of the articles that I'll show towards the end show that they do offer very sort of variable functional outcomes as compared to reverse total shoulders. So the most common complication for this procedure is shoulder dislocation. The incidence in the literature is very variable. However, it ranges from 1.5 to 31%. Factors that are associated with an increased risk of dislocation include a BMI over 30, being male, as well as subscap deficiency. Revision procedures have also been associated with shoulder dislocation. Other complications that are commonly noticed include scapular notching, which is erosive lesion of the inferior scapular neck due to impingement by the humeral head. A hematoma, component loosening, fractures of the scapula, infection, nerve injury, and deltoid weakness. The axillary nerve is one of the nerves that you have to avoid when performing this procedure. These are some of the variables that are altered in terms of the procedure itself, technical variables, such as the neck shaft angle of the humerus, the diameter of the glenosphere that you're using, lateralization, also inferiorly positioning the glenosphere, the glenoid base plate tilt, as well as component fixation. These are all known to influence clinical outcomes, and consequently, there is a wide variety of outcomes between implants because you can utilize each in a very different way based on these variables. This is the most common, This is the most common grading system for classifying scapular notching. Severe classification, it goes from grade 1 through grade 4. If you read literature on reverse total shoulders and complications of this procedure, you'll almost always come across this classification system because it's normally used to break down the type of scapular notching in the patient cohorts. And finally, I'd like to speak about two studies. The first one is an article that was published earlier this year in the Journal of Shoulder and Elbow Surgery. It was a retrospective review of prospectively collected patient data by 40 fellowship-trained shoulder surgeons in the United States and Europe. This is a multi-institutional study out of the United States and Europe. And the primary goal was to compare complication rates associated with anatomic versus reverse total shoulders. So the purpose of the study, while it was to compare complication rates. The reason for it was because when reverse total shoulders were originally introduced into the United States in 2004, there were quite a few sort of papers that were published in the early term that stated that complication rates for this procedure range from 0 to 75%. It was very variable. However, that complication rate has reduced dramatically, and this could be due to differences in reporting, surgeon experience, indications for the intervention, as well as implant design, which has improved significantly since that time. So this study had two cohorts. The first cohort was the anatomic total shoulder arthroplasty cohort, which had 2,224 patients. And the second cohort was a reverse total shoulder arthroplasty group, which had a little bit over 4,000 patients. There were more females than males in each of these cohorts, and patients with revision of a prior placed hemi or total shoulder arthroplasty or diagnosis of a proximal humerus fracture were excluded from the reverse total group. These are the main results from this study. While there's a lot going on in these two tables, I think the main takeaway is that the anatomic total shoulder is associated with a significantly greater overall complication rate as compared to the reverse total shoulder. In the anatomic group, overall, it was 10.7%. In the reverse total group, it was 8.9%. There was also a significantly greater overall rate of revision in the anatomic group as compared to the reverse total group, 5.6% in the anatomic group and 2.5% in the reverse total group. Infection rates were similar for both. They were not significant from each other. However, they were clinically significant. So the anatomic total shoulder group was 1.3% and the reverse total was 0.9%. And the two most common complications, as you can see in this table, for anatomic included subscap and rotator cuff tears and aseptic glenoid loosening. And then for the reverse total group included acromial or scapular fractures, as well as instability, which is a way to measure dislocation as well. And this is the second study that I thought was interesting. This study was published in 2012. And while it's a little bit older, I thought that it was very interesting because it compared hemis with reverse total shoulders. So similar authors to the prior study, and essentially it was a retrospective review of prospectively collected data, again, from 97 to 2007, single surgeon, single institution study, two cohorts, hemiarthroplasties and reverse total shoulder arthroplasties, 20 in the hemi group, 36 in the reverse group. Mean follow-up was 4.4 years. However, each of the patients that was included in the final analysis had to have at least 2 years of minimum follow-up. And the main result from this study was that after 2 years of follow-up, the mean shoulder pain and disability index score, which is seen on this side, it was one of the patient-reported outcome measures that was given to patients on their pre-op and post-op visits, was significantly better or lower in the reverse total shoulder group as compared to the hemiarthroplasty group. The complication rates for both groups was 25%. And in terms of the main takeaway from the results as broken down here, there were no significant differences in pre-op index scores between the hemi group. Sorry, let me move my mouse. Between the hemi group or the reverse total group. However, post-operatively, the index score improved significantly at 6 months and also stayed improved beyond the 2-year mark. Active elevation was not significantly different between the two groups preoperatively. However, at every time point post-operatively, as can be seen here, the reverse total shoulder group had a significantly greater elevation when compared to the hemiarthroplasty group. For active external rotation, preoperatively, the reverse total shoulder group had a significantly better active external rotation compared to the hemiarthroplasty group. However, the hemi group had significantly better external rotation at 3, 6, and 12 months. However, after 2 years, this difference was not significant any longer. And finally, for active internal rotation, there was a significant difference at the 1-year mark between these two groups. And that can be seen in this table as well. However, I think you need to understand these results for both of the studies that I mentioned in the context of their limitations. Both are retrospective studies, they're non-randomized, so there's a very high risk of selection bias. The sample size for this study was especially small, so you have to be concerned about the project being underpowered, whereas the prior study, there were a couple thousand patients in each of the cohorts, so that might not be as big of a risk in that study. Additionally, in this second study that I presented, comparing the hemi and the reverse total shoulder arthroplasty groups, there was a significant difference in age between the two groups. The mean age in the hemi group was 64 years, whereas the mean age in the reverse total group was 72 years. So another concern is that the results from the study are not generalizable to the general public. And these are my references. Thank you.
Great job.
I have a question. Are you taking any questions?
Oh, sure.
Anyway, that's a very nice review. I have a question unrelated to the surgery, which you reviewed nicely. You presented a case that with 1 month of pain in the shoulder, and then you showed us the reverse shoulder replacement. Can you explain, or do you know why the patient had only a month of pain, yet the x-rays you showed looked like they were years of problems? In other words, that cuff tear arthropathy didn't occur overnight. It didn't occur over a month. It happened over years, yet the patient only had pain for a month.
Right. I think I might have misspoken at that point. She had pain for years. However, she originally presented with right greater than left shoulder pain and then underwent hemiarthroplasty on the right side. After the procedure was done, for some reason or another, it could be the pain control that she was having. Her left shoulder did not bother her as much. However, once it started bothering her again, within a month after that pain restarted, she came back to the office for another follow-up visit. But she's had that pain for years.
Is there anything you could do for someone who has acute severe pain on chronic mild pain? Because she lived with the chronic mild pain for years, right? Didn't seek medical attention until it got severe. Is there something that happens, particularly in seropositive rheumatoids?
I would assume that the adequate pain control would be something that could help with her specific case. But I think the other issue to mention is that she had Hep C, and she was on immunosuppressants. And I think within the past year or so, she had a change in her medication and treatment for her inflammatory conditions. And so as her physicians were trying to find a balancing act between treating the inflammatory conditions as well as kind of keeping an eye on her Hep C, I think somewhere along the way, her shoulder pain reemerged. So I think adequately controlling the inflammatory process, providing adequate pain control and physical therapy were good options for her. And I think she had tried them for an extended period of time. And once that failed, she came to the clinic again.
That's an excellent response. I just think that's important to tell the audience, because rheumatoid flares are very common. And what you just described is a reason. She changed her medication. She probably got a flare. They weren't able to control it with either medication or maybe cortisone injections, because all these people have flares that go away sometimes in weeks or months. And if you just change their medication, so it's important to tell people that, particularly when someone's had chronic mild pain for years. But that was exactly the answer to that question. Thank you.
Definitely. Thank you.
You know, Akhil, just to build on Dr. Kirschenbaum's comment, you know, one thing that was a little concerning to me when I listened to your talk is her comorbidities. You're talking about a patient that has rheumatoid arthritis, lupus, and hepatitis C. And, you know, I don't have a ton of experience with reverse shoulders, but I do know that if there's a problem, it's a big problem. And a lot of times getting fixation on the glenoid and making sure that base plate stays intact is important. And with rheumatoid disease, you can have weak bones. So just another option to mention, and I don't know if the treating surgeons out there, is potentially using a cuff tear arthroplasty head, which is something you didn't mention, but it's something that should be mentioned, and that's a larger head. It changes the moment arm, and it might be that nice kind of balance between doing too little and too much in a patient with multiple comorbidities.
You're talking, nice talk, nice review on it. In your talk, you mentioned how cases very rapidly blossom. And anytime, there's new technology coming out and you see that kind of expansion, it always, I don't know about everybody else, it always makes me a little bit nervous. And reference the indications without really talking too much about that. Is in your reading, did you come across any particular controversies as to, pushing the indications levels and where we should be with that?
I did not see specific studies on how indications are related to this procedure. I think partially this could be because the studies that have been conducted on this topic, the way that they conduct them is that they have strict inclusion criteria where they're only looking at patients with rotator cuff arthropathies. Consequently, you're seeing better results in that group. However, I think that would be something that would be really interesting to study in patients such as who have like osteoarthritis, and that's not like a primary procedure necessarily that the FDA approves it for, but has been used in.
So the question I'm having is sort of a question. I'm thinking about a question. Some of the studies out of Europe fairly early on talking about doing reverse total shoulder arthroplasties for rotator cuff tears, and a lot of them were done. That when we were doing cuff tears 20 years ago with first generation suture anchors and still using bone tunnels, the success rate of that early on was quite good, and it lasted well for about 10 or so years. But then those cuff tears started to fall apart. I think more modern techniques of fixation and so forth, but cuff tears, if they're done well, can last a lot longer than that. Repairs. So it's one of those things where I wouldn't necessarily want to bail out chronic rotator cuff tear or rotator cuff tear without trying to fix that first. Everybody has their own cutoff. It's like a cuff tear that's 3 months old. Well, that might not be repairable. That may be true, but I've done cuff tears for 3 years old. It's rise from years by, it can still be repaired and be reasonably well. It's not a home run ever, but it can be well, and it's a significant step shy of doing a reverse arthroplasty where you're really dancing on a tight wire without a net. There's not a whole lot of bailout with your reverse shoulder doesn't go that.
Right.
So anyway, to sort of round out concepts, because you touched on all the stones, as far as I'm concerned, with the exception of that one thing, picking and choosing the patients is really, and in your case, is apropos of that. It's still a little bit of a challenge because criteria are all over the map.
Yeah.
I would argue against it.
How did your patient like her right shoulder?
She seemed to like it really well. So this is a post-operative CT scan of her right shoulder. The reason why she got a hemi on that side was because she had a really large osteophyte that precluded reverse shoulder fold replacement. She did well.
So the hemi was also done in because she didn't have very kind of foreign stock on the right side, but she did good pain relief. She did not have great overhead. So I think that was partly why the left side, once you got the CAT scan, going to be a good one at one side to the left, that was sufficient for a reverse. That's why cut Monica elected to. You want to do a reverse on both sides, but the right side was yeah, both present.
That's a good choice. If you don't think you can get that, well, that's the danger.
Yeah, the right side. So that giant can you be now? We tried to get it the other way and it's still there. So
when you do this, excavate all around the runway. I'd argue that you need to make that choice before you start taking all that stuff.
yeah.
A large, and Brian Cat referenced, if you can put in one of those larger or lower couple of heads, drive even on that soft tissue, or they just move all over. It's hard to call it a dislocation. There's no dislocate out of that.
We had templated this one with like a computer model at the time, it looked like we fit to give it a try.
And that was on that scan.
Thank you. That was a picture of my dog on that side of the last slide. It's my dog.
So good morning, my name is Amber, and today I'm going to be presenting on carpal tunnel syndrome. So today I'm going to be reviewing the relevant epidemiology, anatomy, risk factors, and diagnostic techniques, and discussing sort of the role of electrodiagnostic studies in the diagnosis. I'm also going to be reviewing some of the non-op and operative management we have available and integrating literature on the topic. So just to start off with our case, we had a 56-year-old right-hand dominant female who had initially presented for about 2 years of numbness and tingling over the first 3 digits on the right hand. She was also saying that the symptoms were particularly bad at night. She had initially presented to another physician about 7 months prior, and they told her to try some ibuprofen and wrist splinting, which she did try and said that they were actually pretty helpful for a while, but her symptoms started to recur and get worse again, so which is why she re-presented. Otherwise, other history was non-contributory. On exam, she had a positive Tinel's, Phelan's, and Durkin's compression, and her motor exam was normal, and there was no evidence of any thenar weakness particularly, and no visible thenar atrophy. Sensation was also intact to light touch over the palm. She had also had some outside electrodiagnostic studies performed, which showed evidence of increased sensory and motor latency, but there were no changes on her EMG. So just to go over some of the relevant background for carpal tunnel syndrome, it's the most common compressive neuropathy occurring in about 5% of the population. It's actually pretty common for it to occur in both hands, up to 50 to 60% of patients. Usually the course of this is it will start in the dominant hand and then several months later start presenting in the other hand. It's particularly common in women. The reason this is thought to be due to a few different reasons, including hormonal changes, which can create fluids within the carpal tunnel, which can lead to compression, as well as some conditions like hypothyroidism and rheumatoid arthritis are more common in females, which are also associated with carpal tunnel and has a bimodal age distribution. So just to go over some of the relevant anatomy really quickly, the median nerve runs through the carpal tunnel and the transverse carpal ligament. It's a pretty tight space because there's also the 9 other flexor tendons running alongside it. So typically when inflammation of the tenosynovium occurs, this can lead to compression of the median nerve and give the common symptoms, as you can see in the bottom here, of numbness and tingling in this distribution. Another important thing, they can also present typically with night symptoms. This is usually because patients have a tendency to sleep with hand flex, which can compress the median nerve. And there can also be loss of 2-point discrimination, as well as visible thenar atrophy and severe disease due to the loss of the intrinsic muscles. Another important thing, just the palmar cutaneous branch of the median nerve typically arises about 6 centimeters proximal to the entry into the carpal tunnel, which is why palmar sensation is typically preserved in carpal tunnel syndrome and can be differentiating from other conditions that present similarly. Another thing to go over is the recurrent motor branch. This is usually a branch that can be injured commonly because it has such a variable course. There's been a few different studies that have both in cadaveric and observational studies that have examined this and broke it down into a few different subtypes, including the extraligamentous, which is the most common, where, as you can see here, the motor branch divides after the median nerve comes out of the carpal tunnel, as well as, and this is like about 50 to 60% of the population. About 20 to 30% have what's considered to be the subligamentous subtype, which you can see in D, where it arises within the carpal tunnel, but sort of branches out after. And then the last one is the transligamentous. This occurs in about 10 to 20% of the population. This is the one that's usually at risk for injury during a transection of the transverse carpal ligament because it pierces directly through the ligament. And also around 10%, there's other subtypes, and around 10% of the population have multiple branches of this nerve. So there's many risk factors that can lead to a patient having carpal tunnel syndrome. And they usually fall into two categories, either those that will lead to increased inflammation of the tenosynovium, such as smoking, or those that will lead to sort of mass effect within the carpal tunnel, which will cause compression, such as, you can see here, things like amyloidosis and hypothyroidism. To go into sort of one of these risk factors, which is amyloidosis, was the subject of a recent study by Sperry et al., where they evaluated 98 patients undergoing carpal tunnel release. And during the open release, they would take a little biopsy of the flexor tenosynovium, which was then sent out for Congo red staining to evaluate for amyloidosis. What they found is about 10.2% of patients had a positive biopsy for a type of cardiac amyloidosis called transthyretin. And they sent these patients then for further workup. And what they found is about 3 patients ended up having the genetic form of this disease, and another 2 patients ended up having a non-genetic form of cardiac amyloidosis, and they were started on therapy. The typical course of this condition is that the carpal tunnel syndrome symptoms present about 5 to 10 years before symptoms of the cardiomyopathy. So the authors of this study suggest that these patients should undergo a biopsy, since it's relatively innocuous and could lead to treatment before symptoms start occurring and getting troublesome. Just to get a little bit back into the diagnosis of carpal tunnel syndrome, there's no real algorithmic way to define carpal tunnel syndrome. Instead, it's a clinical diagnosis based on your use of the patient's exam and their presenting history. A few different things we have in the tool belt include the provocative tests like the Durkin compression test, where you place direct pressure over the median nerve through the carpal tunnel to reproduce symptoms. This is generally considered to be the most sensitive test for carpal tunnel. And you also have Phelan's, which involves flexion at the wrist to reproduce median nerve compression, and Tunnell's sign, which is tapping over the median nerve as it runs through the carpal tunnel to lead to those paresthesias. These both have pretty variable sensitivities and specificities through all the studies that have examined them. And this is in large part thought to be due to different interpretation by physicians and researchers on how to interpret these tests. You have some other testing like the Semmes-Weinstein monofilament testing, typically used to look for loss of 2-point discrimination. And you can also look at things like atrophy of the thenar muscles, which you can see in the bottom here in more severe forms of disease. As far as imaging, the nerve conduction studies and EMG are typically considered to be the gold standard of diagnosis, but it's pretty controversial since you don't even really need these studies to diagnose carpal tunnel. I'll kind of go into some of the reasons about this. And more recently, ultrasound and MRI have been used for diagnosis. Just getting a little bit more into some of the problems with EMGs and the controversy. There was a study by Florian et al. Recently in 2017 that looked at people who had the clinical signs of carpal tunnel syndrome, but normal electrodiagnostic studies. They examined 57 of these patients and allocated them into a 2-to-1 randomized fashion to either surgical treatment or non-surgical treatment. With the non-surgical group, they either received steroid injections or wrist splinting and ibuprofen. These patients were asked to fill out like a subjective scale of 6 points on their symptoms, both at baseline and at 6 months after the surgery, as well as the validated Boston Carpal Tunnel Questionnaire, which asks patients questions about their symptom severity and their functional outcomes. And what they found actually was that significantly more patients who were surgically treated were completely asymptomatic or had clinical improvement compared to those who were treated conservatively. And also on here, on the different aspects of the Boston Carpal Tunnel Questionnaire, those who had surgical treatment had significantly lower scores compared to non-surgical treatment for both aspects. And kind of really the main takeaway from this study is that even with negative electrodiagnostic studies, this does not preclude a patient from getting surgery. Just another study to sort of belabor this point. Dr. Graham looked at the value added by these electrodiagnostic studies for carpal tunnel syndrome, and he had used what was called a CTS-6, which gives an estimate of pretest probability for carpal tunnel syndrome on 6 factors. So it looks at numbness in only the median nerve distribution, nocturnal numbness, thenar atrophy, positive Phelan, positive Tinel, and loss of 2-point discrimination, and estimates pretest probability based on that. They were then underwent electrodiagnostic study, 143 of these patients, and a post-test probability was calculated based on that. So this is on the x-axis, you can see the pretest score, which is associated with pretest probability, and on the y-axis was the change in score after electrodiagnostic testing. For actually people who had pretty high pretest probabilities, electrodiagnostic studies didn't really do very much, if anything. It was really most of what was seen was on patients who had under 50% pretest probability. And usually what happened is the electrodiagnostic studies reduced that probability to even lower. So then what is the role for electrodiagnostic studies in carpal tunnel syndrome? It's kind of like Dr. Graham had shown, is pretty helpful when pretest probability is not very high and you're considering other diagnoses. It can also help stratify disease based on the results. There's been a few different ways that this has been done, but sort of a simple way is that patients who only have increased sensory latency are considered low probability or sort of mild disease. Patients who have also increased motor latency are moderate disease. And once you start seeing EMG changes, that's considered to be severe disease. And why is that helpful to stratify these patients? It's kind of important because electrodiagnostic studies have been shown to be associated with prognosis after carpal tunnel release. So there's been a few studies. The one I kind of show here on the right is Cromledge et al. In 2015, compared patients, stratified patients with severe and moderate carpal tunnel based on these electrodiagnostic studies and followed them up to a year out on their symptom severity. Patients with severe carpal tunnel did significantly worse up to about a year after surgery. And sort of, they had one patient, which is about 2% of the population with moderate disease, who continued to have symptoms up to a year, but 20% of patients with severe disease had symptoms up to a year. So that's kind of important when seeing these patients on counseling them about what to expect after surgery. Just some of the more recent imaging that's been used recently. Ultrasound is starting to get really popular. There's a few different ways that they evaluate median nerve compression, but they usually use the cross-sectional area of the nerve on ultrasonography. There's a study by Mugelli et al. Where they found no difference in the sensitivities between electrodiagnostic studies and ultrasound. And actually, when both were used together, the sensitivities were increased even higher. One of the things that they note in this study is as they trained all their staff to use ultrasound for this study, it was actually pretty easy to teach everyone, and the reliability between different providers was high. There's also the added factor of patients tend not to like electrodiagnostic studies very much because of all the pricking that happens, whereas ultrasound doesn't have that same problem. MRI has been recently used in a 2017 study, and it was found to be highly sensitive, but it's not very specific for carpal tunnel syndrome. One thing is that based on evaluation of the MRI, you can determine which patients might benefit from surgery. It's not perfect though, because it's based on anatomy as opposed to patient symptoms. But the issue with MRI, of course, is that it's pretty expensive compared to something like ultrasound or electrodiagnostic studies. So then really the kind of niche it's found for itself is that for patients who have secondary carpal tunnel syndrome, maybe like a nerve sheath tumor or some other compressive thing, or for determining the reasons why surgeries failed. So just to start off on non-operative management, this is typically what's used first in patients who present with carpal tunnel syndrome. And you have a few different options like NSAIDs and educating patients about activity modification. One important thing to note with splinting is that it's really only been shown to improve symptoms in patients who initially present with nighttime symptoms. As I explained earlier, it's because of that flexion at night. So if patients aren't really presenting with nighttime symptoms, it tends not to help out as much. And also corticosteroid injections. About 80% of patients report a transient improvement in symptoms with corticosteroid injections, usually last in the range of like 1 to 3 months. And with a smaller subset, about 20% of those patients having relief up to a year. The thing with the corticosteroid injections is they're not only therapeutic, they have some diagnostic value as well. It's another thing in your tool belt. Patients who improve after corticosteroid injections, it can be something to suggest carpal tunnel syndrome to another condition. And also it's prognostic. Patients who don't have any relief following a carpal tunnel injection have done worse clinically after surgery. To get more into the operative management, this is typically reserved after non-operative treatment has failed, but sometimes it's used initially in people people who will initially present with more moderate to severe carpal tunnel symptoms, and in people who present with evidence of innervation, and with people who have acute carpal tunnel symptoms, such as after a distal radius fracture. There are two main techniques that are primarily used. The open technique, which has sort of been recently modified into the mini open with a smaller 1.5 to 2 centimeter incision. Those studies kind of comparing these two haven't really found any significant difference in complications or outcomes. And also the endoscopic release, in which 2 volar incisions are made, one to advance the endoscope and another to put in your tools to incise the transverse carpal ligament. It's a pretty hotly debated topic, but generally long-term outcomes, surgical times, things like pinch and grip strength, and our validated scores are generally all the same at long-term follow-up. Proponents of endoscopic release will point to studies that have shown that patients tend to be satisfied with endoscopic release and have lower scar-related complications. And it also does have a modest reduction in return to work time, about 9 days median. The main complication for both of these procedures is incomplete resection of the transverse carpal ligament, as well as iatrogenic injury to the nerves, like I discussed before, or the tendons. These usually, on meta-analysis, these tend to be higher in patients undergoing endoscopic release than open. So usually it's a relative risk of about 2.38 of a neuropraxia with the endoscopic technique. And just to go back to scar tenderness, it's a little lower, it's about 0.73 on meta-analysis. And just quickly to get into one of the newer techniques that's being used, partially due to the anatomic variability of some of these nerves and vessels, is using ultrasound to sort of map out the patient's nerve patterns before surgical treatment. And essentially after you do that, they use anesthetic to create what's called a longitudinal safe zone within the carpal tunnel, which you can then incise under ultrasound guidance. So there haven't been too many studies on this recently. The largest one is this one from 2017 by Petrova et al., which examined 129 patients with carpal tunnel syndrome using this technique. They evaluated these patients at baseline and then at 1 and 6 months using the Boston Carpal Tunnel Questionnaire and MRI imaging. And what they had found actually is that over time, both aspects, the symptom severity and functional status, tended to improve up to 6 months after surgery. And on MRI, what they had found is that all patients had complete resection of the transverse carpal ligament, and they reported no complications. There's been a few other smaller studies which report some complications, but nothing higher than the 2 other techniques that are commonly used. So just in summary, carpal tunnel syndrome is a clinical diagnosis primarily. Its electrodiagnostic studies do have their pitfalls, but they're useful in certain cases and for prognostication. And surgical technique is generally based on physician preferences, as long-term outcomes are the same and rates of complications are usually related to physician comfort with the technique they're using. And ultrasound shows promising clinical utility for diagnosis and treatment. Thank you.
Hey, that was a great presentation. I have a question for you. So if you had a patient and you were a hand surgeon after you're done with your residency that had numbness and tingling in their fingers for 3 to 6 months, would you get an EMG?
I think there are insurance reasons why you might have to get an EMG sometimes, but I think if the
let's assume this is a cash patient, no insurance.
But I think personally, if I had strong clinical suspicion for carpal tunnel on the exam, I wouldn't.
So you would have to have positive physical findings?
Yeah, like sort of if the exam had the symptoms, the sensory numbness and paresthesias were only over the first 3 digits, and you had positive things like Durkin's, I probably wouldn't get an EMG.
Right. So the studies that show the carpal tunnel 6 evaluation tool, which is exactly what you said, all those physical findings, and there's a point system. And if it adds up to a certain amount, the chance of them having carpal tunnel is extremely high, and there's no need for it. So what happens if they have numbness and tingling, but all the physical findings are negative?
So I think in that case, if they only have numbness and tingling, usually I think the percent chance of that leaves you with a pretest probability pretty under 50%. So I think they're probably useful just because you want to rule out other mimics for carpal tunnel.
Are there any other mimics that you rule out without getting an EMG?
Well, I guess you could, things like pronator syndrome, I mentioned the palmar cutaneous branch, like if you look for palmar sensation, it could help rule out something like that. You could also look at the distribution and help rule out cervical neuropathy, cervical compression, and other things as well.
Right. So, if you had a C6 radiculopathy, you can rule that out clinically as well, right? So you could do all the clinical exams for that. So you can rule out almost everything, but not everything, but most things. So a good physical exam usually is all that's needed, but there are certain cases where you could even get a double crush. So when you're not sure, that's the case, that's the time to get it, because are there any other things besides cervical radiculopathy and peripheral neuropathy that can give numbness and tingling and create basically a double crush? They have some findings, but there's something else going on. Is there anything in women that could present as numbness and tingling, primarily in women, not to be discriminatory? Is there any neurologic problem that could present as carpal tunnel?
I'm thinking sort of diabetes, the peripheral neuropathy can present pretty similar.
No, a neurological problem, more central, seen primarily in women, that could sometimes present that way, but oftentimes there's that plus lower extremity problems and maybe visual problems and sometimes swallowing problems, but sometimes first presents with what sounds like carpal tunnel. Where there are plaques in the cervical spine.
Oh, would that be like multiple sclerosis?
Right, yes, right. So you always have to think of those as well.
Amber, I thought that talk was excellent. Thank you for doing it. I just want to make two quick comments. One is we did do that study that was published last year in terms of the EMG negative patients. And then we ended up giving them a diagnostic cortisone injection. And if they responded to the cortisone injection and they had symptoms, 90% chance that they'd have improvement with surgery. So the EMG can be negative in these people, but if the EMG was negative and the cortisone injection was negative, there was only a 50% chance that they would have improvement. So the finding there was if both tests are negative, you really have to look for other conditions, like Dr. Kirschenbaum said, that can be attributed to the numbness, either the neck or something systemic. So that was great. Thank you.
Thank you.
I'll just add one of these to that, and that is that, and I don't often get the feeling that's I don't use EMG typically to make or diagnosis of carpal. You can do that quickly into the doorway and then a physical thing. However, there are times when it's nice to have somebody that comes in, had a carpal tunnel release, didn't do well, regardless of that it's done, and they had a preoperative EMG. To do a post-operative EMG, they compare studies have been proven that should be very valuable as whether it should be operating that dose or not, particularly if there's other interests at play, or if the work is conflict or parts. And so, the prognostic ability to say, yeah, that patient deserves another look at that carpal tunnel can be enhanced significantly with EMG. Now, the problem is, in my practice, I get routinely, but one of the criteria that I would use is there, it's more of a result. If there are enough red flags, I will get an EMG based on whether I think the diagnosis is in question or there will be potential for pain issues later on down the line. But I don't get it routinely.
Thank you.
You used to get a lot of doing your own ultrasound.
Oh, I wanted to make one of that too. So there's sort of two different schools of thought. You look for depression, and pinching, if you will, of the nerve underneath the body, or you look for pseudoneuroma proximate to that. And I think the pseudoneuroma proximate to that is a little bit more sensitive to my end. And I think it's a little bit more reliable because they've got pretty good numbers on that reasonable ratio, the ratio of the down to a while. And again, it's funny, it's a technique that I don't use routinely. You're ultrasounding a lot of them just for injections. For injections, but before you ever start measuring that.
Yeah. Yeah, but I mean, I think the paper's already been written, and it's one of those factors. To make me based on history and a couple of physical exam findings. Do you need an ultrasound proven? I think, with my hands, I feel like, look, here's your nerve. You can see how it's sort of underneath the front ligament, sort of pressure. If I roll a little bit higher up the forearm, you can say, okay, we'll do a measurement, and you can see evidence of the robot. And again, just like you can have somebody roll in that has normal treatment, they have carpal syndrome. I mean, legitimately, even maybe the carpal release. You don't have to wait until it's EMG changes. And I would say the same for the ultrasound. If somebody's symptomatic enough and they're walking like that in practice, they can get a carpal release, or you can confirm it or diagnostic or diagnostic. And give confidence. And again, of course, every once in a while, you get somebody steroid shot that's fairly mild symptoms, and it will go away. Get off the screen.
Thank you. Hi, good morning, everyone. My name is Wilford. I'm one of the fourth-year medical students rotating on the joint service. My topic today will be on unicompartmental knee arthroplasty, also known as partial knee replacements. So for the objectives of my talk, I want to identify which patients are candidates for these partial knee replacements, as well as discuss some of the risks and benefits of partial knee replacements and review the literature for which patients are ideal for partial knee replacements. So for our case, a patient's a 76-year-old male with 1-year history of worsening right knee pain that is aggravated by anything like walking, standing, and range of motion. He was diagnosed by an outside physician with osteonecrosis of the right femur condyle, and he's been managed with conservative management, including things like cortisone injections, hyaluronic acid, as well as physical therapy and anti-inflammatory medications, but none of them have really provided relief for the symptoms. For the past 2 to 3 months, the patient's symptoms have been worsening, so he comes to the clinic to discuss surgical management for his condition. So this is the imaging for the patient. This is an APM lateral view of the patient's right knee. And you can see on the medial condyle an 11 millimeter wedge-shaped radiolucent lesion, which is pretty consistent with the osteonecrosis of the knee. So what are the treatment options for osteonecrosis of the knee? And broadly speaking, there's 2 categories, whether it's conservative management and operative management. So this patient has been undergoing conservative management for his diagnosis, and that includes things like NSAIDs, physical therapy, as well as protective weight bearing. And in early stage osteonecrosis of the knee, this usually shows an excellent response with greater than 70% of patients showing complete resolution of their symptoms within 3 to 8 months. But unfortunately, if the symptoms don't resolve within that time period, there is risks of progression if the conservative management fails. So in that case, patients will then be candidates for operative management for things like either joint preserving surgeries or knee arthroplasty. So unfortunately for this gentleman, since it's been 1 year since he's been diagnosed and he hasn't had any resolution of his symptoms, he is a candidate for joint replacement surgery. So to provide you basically 2 goals, one which would be relief of his symptoms, as well as to prevent progression of the disease to end-stage arthritis. So as a brief overview of what these partial knee replacements are, so the definition is that it's resurfacing of one tibiofemoral or one patellofemoral compartment. And you can see on this diagram here, where only the medial compartment has been resurfaced. And it's only a bony procedure, which is in pretty sharp contrast to a total knee replacement where the ligaments are all spared. You can see that the ACL, the PCL, the LCL, and MCL are all still intact. In a total knee, there's extensive soft tissue release usually done to get the proper mechanical axis alignment. And that's not the case in partial knee replacement, where
it's only a bony procedure, and the native knee kinematics are all preserved. Out of all the arthroplasties done, around 5% of them are these partial knee replacements, and the medial compartment is usually the one that is most commonly done, since that is where osteoarthritis usually begins. So for the designs for the partial knee replacements, it usually comes in two flavors. There's the fixed bearing design, and then there's the mobile bearing design. And that all relates to the poly-bearing surface on which the distal femur component is gliding on. So in this picture here, you can see that the poly-bearing surface, it's one long rectangular sheet where the femur component is just gliding on one single point of contact. As you can imagine, since it's only one single point of contact, there's going to be a lot of forces being transmitted, which equals to a lot of pressure over one single area. Compare that with the mobile bearing design, and that instead is a wedge-shaped poly surface that is concentric with the distal femur component, and it's free to glide along the tibial base plate. So you'd be able to increase the surface area over which the pressure is being distributed. So it's lower pressure for the surface area. And so these are just x-rays for these two different types of implants. So on the left is just a fixed bearing one, and on the right is the one with the mobile bearing. You can tell it's the mobile bearing because it has a radiolucent marker on it. So what are some of the benefits of doing a partial knee replacement versus a total knee replacement? These are two retrospective studies I found looking at that. And as you can imagine, since the partial knee replacement is a less invasive and less aggressive surgery, you're going to have outcomes such as decreased postoperative pain with shorter hospital stays, reduced blood loss, which will translate to less postoperative morbidity, as well as a faster rehab time and quicker recovery, as well as improved functional scores. And it's been quoted that usually patients will have a faster return to a more functional level than if they had a total knee replacement. So which patient is the ideal candidate for getting this partial knee replacement? So historically, one of the first proponents for partial knee replacements was Dr. Cousin and Dr. Scott from Harvard in 1989. Around this time, a new generation of the partial knee replacements had come out, which demonstrated superior outcomes. So they wanted to develop this sort of criteria for which patients would be the best candidates for it. And since then, it sort of served kind of as the gold standard for choosing which patients are the best candidates to get partial knees. And they're over here on the right, and I'll go through each of these indications. So one of the first categories of indications is that you want to have disease in just one compartment. And that's pretty self-explanatory. If a patient has disease in multiple compartments, doing a partial knee replacement is ultimately not really going to solve their problem. If they're going to need to get a revision to a total knee, then just use a total knee instead at the beginning, instead of just going with a partial knee. And you can see radiographic images of that, of what I'm talking about here. So in this first image on the left, the patient has a bone-on-bone arthritis in the medial compartment with a healthy contralateral side. And on the image on the left, they have more severe bone-on-bone arthritis on the lateral side with a healthy medial side. So based on these two images, these patients would be candidates for getting partial knee replacements. The next criteria is which patients would be the best ones that would not outlive or outstress the designs. So because these partial knee replacements, they're smaller and more fragile, usually you're going to want to have patients that are older. Dr. Cousin described that as patients that are older than 60, as well as patients that are light, so they won't overstress the implant. So patients less than 82 kilograms, as well as patients that are have low activity levels. And then one of the contraindications that was stated for partial knee replacements is that the disease that they're having, you want to make sure that it's not inflammatory or any crystalline disease. And the reason for that is because if you're using the partial knee replacement, it's ultimately not going to resolve their symptom or their disease. An example to describe that is if a patient has rheumatoid arthritis and they have a disease, just one compartment that's diseased, if you do a partial knee replacement, ultimately it's not going to solve their rheumatoid arthritis, and they're going to develop disease in the contralateral side. So keeping that in mind, if they have risk of progression of their disease and the partial knee is not going to solve it, then you just want to go with the total knee replacement instead. And so in another category is that since this partial knee replacement is done as only a bony procedure and none of the ligaments or soft tissues are released, you want to make sure that the patient does not have too much deformity within their knees because you're not going to be able to correct that. And ultimately, with all these indications, you can imagine that very few patients are going to qualify and have all these indications to get partial knee replacements. And that's sort of been a point of contention amongst the literature because less than 6% of patients actually qualify. And a lot of the indications that Dr. Cousin and Dr. Scott came up with, it's basically based off observational data. There isn't a lot of hard science to support it. So in the early 2000s, Dr. Scott from Harvard, he came up with these two literature reviews, just looking at those criteria again and just reevaluating which ones can be used or which ones can be amended. And some things like age restriction, they could be amended and they could be increased. Weight restriction did not have to be so strict. Could be increased up to 90 kilograms. And some of the deformities as well did not have to be as strict as well. And so this graph sort of describes where these criteria sort of fit within today's literature. The initial criteria back from 1989 that Dr. Kazan posited up on the left, you can see that only out of the original 10 or so, only 3 of them, the current literature still agrees on. Most of them, there's come out new literature, either contradicting it or expanding upon those limitations. So more patients are qualified to get partial knee replacements. Another important thing to look at is just the survivorship for partial knees. One of the issues with the partial knee replacements is that unfortunately they don't survive nearly as long as total knees. So you can see on this graph, the orange line is the revision rate for partial knees versus the green line, which is the revision rate for total knees. So even within just 4 years, the revision rate is significantly higher for partial knees. And also the survivorship data is fairly limited, the long-term survivorship. So for the fixed bearing design, it's been quoted that it's around 90 to 95% of them survive throughout the first decade, and they drop off fairly steeply into the second decade at around 80%. Mobile bearing, there isn't as much data available so far. 15-year survivorship has been quoted around 93%, so it's a little bit more promising. But one of the issues just with this kind of data is that most of it is from the company, so it's not the most reliable data out there. And the consensus among the orthopedic community is that partial knee replacements basically provide improved outcomes with an inferior longevity. So some of the causes of failure for the partial knee replacements, the most common one overall is progression of disease. And you can see that in this X-ray over here. So in figure A, the patient initially had osteoarthritis within the medial compartment, and they were indicated and got a partial knee replacement done. Then you can see in figure C and figure D that the contralateral side started to develop arthritis as well. So this patient's going to need to get a revision into a total knee. And there's certain factors that can contribute to that. Choosing the correct patient, adhering to indications can really limit that. So making sure the patient doesn't have any risk factors, such as, like I mentioned before, like rheumatoid arthritis, or that they don't have too much deformities. That's the main factor to limit this, but surgical technique as well can play a role. If there's overcorrection of one side with the partial knee replacement, you're going to drive the contralateral side into too much valgus or varus, and that can really progress the disease, the arthritis on the other side. The next most common mode of failure is polyethylene wear. So this is commonly seen, it's with the fixed bearing designs. And as I was mentioning before, since it's just one point of contact, a lot of pressure is going through a very small area. So the components will just grind away at that polyethylene, and it accounts for around 12 to 25% of failures. So late mode of failure is seen usually around 8 to 10 years after the implant has been put in. And you can see that, especially in figure D, you can see just how much the polyethylene has been chewed up by the implant design. And so the options for that usually are either to exchange a polyethylene component or to go under a revision to a total knee. A little bit rare complication, seen around 1.5 to 4.6% of the time, is bearing dislocation. This only occurs with the mobile bearing design. And you can see on this X-ray, so the first image on the left is the initial post-operative image for the patient, and then the bearing dislocates. You can see that in the second and the third picture. And this is an early finding, usually seen it's within the first 2 years of the first 2 post-operative years. And a big component or big reason that this occurs is often usually due to technical errors where the components are either mismatched or they're misaligned. And oftentimes this occurs more in the lateral compartment just due to anatomic constraints such as LCL laxity that allows a little bit more free play of the components. So for these kind of patients, the options that they have, because they dislocated once, unfortunately, the issue is still there. So they're going to re-dislocate it. So they'll usually need to have to go under a revision to a fixed bearing design, or they'll have to go to a revision into a total knee revision. Another complication that is commonly seen is periprosthetic fractures, in particular tibial plateau fractures. This is usually a late complication seen if patients develop things like osteoarthritis, and it's commonly seen. It's with the fixed bearing design. Again, with the fixed bearing design, since so much pressure is being distributed over a small area, patients have a predisposition to develop stress fractures, which eventually will result in the tibial plateau fracture seen like this over here. And surgical technique often has a big role to play in this. One of the studies I found was this case series by Dr. Brumby, and he found that one of the causes that can lead to increased rates of stress fractures, these tibial stress fractures, is just using too many pinholes or violating the cortex of when you're using the pinhole. So again, just to emphasize how much surgical technique can really play into the outcomes of these patients. So for our patient, after discussing the risks and benefits of surgery, since he had already failed conservative management, the patient chose to undergo a partial knee replacement. He went with a mini incision. They used a Biomet partial knee with a mobile bearing polyethylene liner. You can see pictures of that here in these post-op images. And if you consider the indications I mentioned before, this patient sort of fits all the criteria. He's an elderly gentleman that's fairly sedentary. He has disease only in one compartment with little risk of progressing into into any other compartments. And he had minimal deformity of the leg. So the bony procedure, you didn't have to consider doing any soft tissue releases. So just to summarize for this, this is a quote I found in one of the studies that I really liked. And partial knee replacements, they can be the right surgery for the right patient with the right surgeon. So ensuring that it's the right surgeon, the right surgery, you want to make sure that you're considering partial knee versus total knee. So things like making sure that the disease is only in one compartment, that the disease can't progress into other compartments. You want to make sure again that this is the right patient for this surgery, assessing any risk factors for failure of the implant, making sure that things like the patient isn't a young, very active patient who will probably outlive or outstress the implant. And again, when I was running through the complications, a lot of them can really be affected by surgical technique. So you want to make sure that this is the right surgeon performing this procedure, ideally a joints fellowship trained orthopedic surgeon, especially since complications are more common with these total knees. Revisions and conversions are required more often than total knees. That's it for my presentation. Thank you. So that was done by an outside physician. So he had just come for consulting, or he was referred just for considering surgical management. Yes.
A lot of it is going to affect the entire knee joint. So
yeah, so he was diagnosed. Yeah, so he was diagnosed with.
So I just have to, for those who are online, let's say work on osteoporosis because they have multiple reasons for osteoporosis. It will affect the lateral condyle, it will affect tibia. You see a lot of these patients, I've seen a lot of these knee patients get global throughout the knee, so you got to work that out.
Yeah, so ultimately he had been diagnosed. It was with spontaneous osteoporosis. It wasn't due to a secondary condition. So those causes had been ruled out. Like you said, like there was no steroid use, there was no excessive alcohol use or any metabolic things like shares or random things like that. But
is there an MRI?
There was not an MRI. No.
Wilford, I thought that was a great talk, and you really understand the topic, and thank you for presenting it. I have just two comments. One is, and it kind of touches on what was just said, it's hard to hear the audience, but is a CT or MRI indicated before doing a uni just to make sure there isn't disease in another component? And then my second question is, 20 years ago when I was training, Dr. Tria was just figuring out the instrumentation to do this through these mini incisions. And, if you're not skilled, there can be complications. Is the robot a good place to use, a good instrument to use with unis just because the incision is so small? Did you see anything on outcomes with robots?
Yeah, so for the first point for the MRIs, while I don't remember if the literature supports it, it does make sense to use it since once you see the osteonecrosis on X-ray findings, usually as a more late finding. So Logically, it would make sense then to use an MRI just to identify that there isn't early osteonecrosis in any of the other compartments. And for the robotic use, yeah, it's up and coming, and for now, it seems to be promising, the data. I don't have the numbers offhand, but like you mentioned, just with the mini incision, it makes it easier to be able to navigate in that small operative site.
Where would you find things operatively, anything you're looking for that might change your plan? Open up something you
I guess just something that would indicate disease in any of the other compartments, which I guess you would see once you've opened up there. If you see any damage to, like any severe meniscal damage or things like that. But if you've already done an MRI, you probably would have found that by then.
your patient is doing on.
No.
So that wasn't the one point to be prepared. You don't have an MRI, you can't get going in, but it's really severe carpal.
So the literature currently says that that's not a contraindication anymore for these partial knees. And particularly in the United States, it's really where most commonly when you do a total knee that the patella is resurfaced, but in many places abroad, the patellofemoral component is not resurfaced. So it's not a strong contraindication anymore.
I agree that it's not a strong contraindication, but you're keep out work up beyond the MRI. Need to at least take that into account. And also, right, the patients only have needle compartments in them. But they have an element of they might have so needle. Through that respective study pointed out that it's where hospitals sit. But how we're told we can done in 2021. What percentage of it done? Outpatient surgery.
Yeah, it's a good point. So yeah, this case as well was also done in a surgery center. So that point, might be just a moot point, but yeah.
That's it. Change of time. Good job.
Thank you.
Nice job, Will.
Thank you.